But if it's healing people, we should give them permission to heal and then monitor to see if it's causing harm. And what we find is that when you monitor, it's not causing harm. So I really want to live in a world where we treat adults like adults, give them information, and then allow them to do what's best for them. All right.
Hey, Dr. Tony.
How you doing, sir?
I'm all right. How are you?
I'm happy to be alive. That's all. I mean,
Same here, same here.
so what else do you need?
Exactly, exactly. I just had my head buried in this.
Oh man, get out of here with that. Yeah, that's right. That's it. Yeah, man. Feels like it's been like forever ago.
Yeah? How long ago was it?
2017, I think. And in
Okay.
fact, one of the things I want to do is change the cover a little bit because I'm not really into I don't do a lot of grains and things like
Yes,
that.
yeah,
So
yeah,
I have to change the cover just to reflect. Back then, I was just trying to find a cute cover, but I wasn't really thoughtful. And I think to not confuse people, I'm going to definitely do that. So,
yeah.
but
Okay,
life's good,
okay.
man. I'm just happy to preach this message, man. I'm just trying to
Yeah,
get the
100%.
word out. That's all. That's it.
So you cool if we just get straight into it then?
Yeah, we can do, man. Let's do
Yeah?
it. Let's do it.
Okay, okay.
No need to hesitate.
All right, let's go, let's go. Thank you so much for this. So could you do me a favor? Could you introduce yourself to the audience, just basically saying who you are, how old you are, what your occupation is, and what your mission is?
I'm a 55-year-old family and obesity doctor. I have a master's in nutrition and functional medicine. Um, I, my journey as a family doctor was conventional. I basically tried to heal people by giving them medicines, procedures, and surgeries. I later learned that with all the training, that if I focus on lifestyle, people can actually heal and recover and in many cases reverse chronic medical conditions. So I've really transitioned my practice to more of a metabolic practice where I focus on really doing anything to reduce insulin. Insulin chronically being secreted, hyperinsulinemia is how we describe it, can really lead to 70 to 80% of all chronic illnesses. So when I talk to patients, I say, let's focus on that. I know before
Yeah.
you got to me, you focus on these other things, but if we focus on that, what happens is you can really get more return on investment. So since doing that, my entire practice has changed. The healing has begun, and people just last week before our recording, I took about 7 people off medicines in 1 week. Prior to that,
Mm.
I had gone 19 years before I started and taken maybe 2 people off medicine in 19 years. I've taken 7 off in 1 week. So
Wow.
it's so people come and their hope is restored by taking this approach. So it's been wonderful, man. I can't imagine going back to the disease management doc I was.
Yeah, yeah. And
Yeah.
where is it that you practice?
I'm in the Chicagoland area. I practice on the
Okay.
south side of Chicago, and the south side of Chicago is helpful in terms of reaching people, particularly of color, because it's very much a community of need. So if
Hmm.
they hear from a clinician who understands that your zip code matters, and Inglewood, one of the communities, have a life expectancy on the south side of 60 years. And then you go
Mm.
to Streeterville, downtown Chicago, and it has a life expectancy, I mean, literally a few miles away, 90 years. So it's a 30-year
Wow.
life expectancy gap. And most of it
Mm.
is they struggle for various reasons, but the resources that the people in Streeterville have are different than in Inglewood. So my goal is to, narrow that gap as much as possible and meet
Okay.
people where they are. So it's a passion of mine. And
Yeah.
and since I've been blessed to have this gift of healthcare, my goal
Mm.
is to bring that to the table and help as many people as possible.
As a doctor, you must be battling, the pharmaceutical industry because basically you are promoting metabolic health. You're promoting a way of living that would essentially reduce people's reliance on medication. You've got the ultra processed food and potentially the climate change lobby, who would be saying that meat is the will be the end of the world. So How come you haven't been cancelled yet?
Well, I think some of it is because it depends on where you work. I work in a large health system that allows clinicians to at least have their own approach. We have things we have to follow. For example, the expectation is that diabetics, people with diabetes, better way of saying it, that they are on a statin, right? So, so there's a little disconnect between where I believe and sometimes I compromise. In other words, I'll say to patients, if you're going to take a statin, um, let's take a statin until we reverse your diabetes. We can, and then once we reverse it and we take that off your chart, not all doctors will take it off the chart, but I will, if it's a type 2 a person with diabetes. So I work in a population health organization, and we are accountable, and we're probably the largest in the country. It's called Advocate Health. And what happens in our system is that we're accountable to the health of the patient. So there is this model where if I do a very good job as a clinician and as a health system, we actually can make more money because they give us like a bonus. And you'll see that in other countries where they may reward doctors for doing a really good job. So in my health system, I actually get rewarded to do a good job in terms of reducing the cost of care. Now, having said that, there's another problem. The other problem is that part of the compensation, particularly for Medicare, is based on how sick the patient is. So I actually get more money if my patients have multiple diagnoses. So if you take a person who understands metabolic health, they eat in a way to achieve that, and then their diabetes goes away and their blood pressure goes away, I actually make less money. How ironic is that? So part of the system says heal people and treat them, take care of their care, and then the other part says we pay you more if they have more diagnosis. So I think we need to create a model where we're able to do both. In other words, we're compensated for healing people, and if they have less diagnoses, they're not going to penalize us because we've reversed disease. When it comes to industry, there is a little bit of a problem because if I have, now I'm an obesity doctor. I have I'm board certified in obesity medicine. So imagine an obesity doctor who kind of doesn't want to do those GLP-1 drugs, those Ozempics. And because they have side effects, they can increase your risk for suicidal thoughts and attempts. It can slow gastric emptying to the point where your digestive system doesn't work. It can lead to losing muscle and fat, and increased risk for thyroid cancer, increased risk for pancreatitis. So what I tell patients, let's do lifestyle first. And what I find is that only a small percentage of my patients, even as an obesity doctor, end up on Ozempic. So of course the company won't make as much money, and there's other companies that make the GLP-1s. So there's a little bit of a disconnect. Now we'll always need drugs. My wife is a type 1 diabetic, so she needs insulin, but she doesn't need as much insulin, but she'll always need insulin. So we don't want to demonize the pharmaceutical industry, but we also want the clinicians to say, hey, if I can fix this problem with lifestyle, and they're all taught to do that, but they don't practice that. They'll say lifestyle is important, but they're prescribing the medicine in the same breath. In my practice, I say, let's do lifestyle first. We won't even give you medicine. And then, but, if we do a great job, you won't need it. But if we don't do so well, you may still need it. So I think that we can all kind of work together. But I think I remember seeing a video recently about, trying to cancel keto. Dr. Eric Berg, kind of fussed a little bit about that recently. And ultimately, there is a disconnect between what's effective and what the mainstream will say. And the mainstream will follow the World Health Organization and the CDC and those entities, many of which are giving information that's not suggesting that keto, low-carb, or carnivore are helpful. They're using old information, and the information they're used are based on survey studies, observational studies, data mining. When you do randomized controlled trials, it's clear that for weight loss, diabetes, and many health conditions. We should not be afraid of low carb, keto, or carnivore. We should actually embrace it. But it's still, the mainstream takes forever. And again, there's politics and lobbyists and other issues that we don't need to get into. I just think that we just need champions like myself, yourself, who are out there saying, guys, this stuff is working. It healed us. It's healing the people in the community. And people should have options to choose options that work. Even while we're still doing research, we don't have randomized controlled trials for carnivore, but if it's healing people, we should give them permission to heal and then monitor to see if it's causing harm. And what we find is that when you monitor, it's not causing harm. So I really want to live in a world where we treat adults like adults, give them information, and then allow them to do what's best for them.
So the thing that I come across, or the resistance that I come across when talking to friends and family, is, the medical industry, doctors, they're intelligent people. Otherwise, they wouldn't have got into medical school. So the issue then becomes why you have a majority of doctors, you have the conventional belief being so opposite and counter to the whole meat-based the meat-based movement. Like how do you explain away that?
Well, I explain it because we are expected to follow the standard of care. If I don't follow the standard of care, people will consider me an outlier, a doctor who doesn't understand the science. And so what's happened is that when I took my journey to understand, what nutrition is, when I got my master's in nutrition, understand that we weren't really focused on the root cause. We were focused on managing disease, not healing disease. When I started to be skeptical about, like, if you have a person in front of you who is not healing, but you keep telling them the same thing, and then you never pause and ask yourself, is there something about my advice that's not correct, right? And people don't do that. They just assume that the patient is not being, we don't use the word compliant anymore, adherent. So you're not being adherent to this plant-based diet. And if you were adherent, you'd be healing. They don't pause and take a moment and say, well, you know what happens when I eat that rice, that brown rice? Does it raise my sugar or not? What happens when I eat quinoa? Does it raise my sugar or not? And what I found is that if you do that experiment, it works. So I just think because doctors are expected to follow standards of care, particularly nutrition professionals, like they literally will lose their job if they deviate. I think about some of the people out there trying to spread a different message. You almost have to leave your nutrition profession to do this. Doctors have a little bit more leeway because I tell my colleagues, the guidelines are guidance. They're not rules. So if you justify that you want to put, somebody has mental health and you want to put them on keto, because you can just point to Keto for Refractory Mental Illness by Dr. Eric Westman and Dr. Georgia Ede and say, I have a study that says this works. So what I do is I document that in my note. But the other clinicians, they don't do that because they don't spend a lot of time looking at nutritional science. They tend to look at what is Ozempic good for? What is metformin good for? They don't look at nutrition. So it requires a clinician to do that and to believe that dietary approaches actually help, and they're just not trained to do that. Most of the lectures they go to will mention nutrition in the beginning, and then the rest of the lecture will talk about the medicine and the procedure and the surgery. So it's really not the doctors or the advanced practice clinicians who are at fault. It's really the system that teaches us to believe in things that are not based on sound science. And most of the nutritional science is based on observational studies. They don't use randomized controlled trials, which is mind-blowing. And it can only show association, correlation, not causation. So until we create a model where that's true, and I would argue Nina Teicholz, who wrote the book Big Fat Surprise, she actually thinks we shouldn't even have dietary guidelines because we're guiding people in a way that's not always good for the individual. So we should figure out how to train our clinicians that here are all the options on the table. Here's the science to support it, hopefully randomized controlled trials. And then we allow doctors and patients to make decisions based on what's working for them, and just have awareness that, oh, by the way, this carnivore thing may be helpful for this. Had you considered that?
Yeah.
Without, and then not demonizing them because they heard that the World Health Organization said that saturated fat or meat is bad. So why did they say it was bad? And is that evidence solid? And the answer is it's not.
Yeah.
So we have to be able to call that out. But most doctors are not aware of that. They follow the headlines, breaking news, just like the patients. So they know as much about nutrition many times as much as their patients. They don't know more. They just follow the headlines just like the patients. So until we fix that, we will struggle. I'm not expecting every doctor to have a master's in nutrition. I'm not expecting every doctor to have board certification in obesity medicine. But I am expecting the health systems to have a place to put people. So if I'm having a problem with weight, we have a weight management program. If I'm having problems with having access to food, we have a way to click a button in our health system, and where's the food pantry near you? So we have health systems that can do that, but we have to align that with the insurer so that the health systems have an incentive to do that. So that's the kind of approach we're opening up. Like we started, I led a food pharmacy model where we give out food and we educate about, and we've had it at a couple of our hospitals, Trinity, and one's called Trinity on the South Side, another called South Sub. We're literally in a couple of weeks going to bring it to another hospital called Christ in a couple of weeks, and that's the type of model we're trying to put in front of people to let them know we do care about food.
Yeah, see, this blows my mind because the system, like I often see stuff about the medical system, particularly in America, not being particularly progressive. And in interviews that I've listened to of yours, your medical institution sounds, the whole thing with the food pharmacy just sounds awesome. It sounds wicked.
Yeah.
Sorry, I use the term wicked. We use that term. We use that term in London, and it means good. It means awesome. So yeah,
that's a good thing. I love it.
Yeah. So I mean, it's you like in your interviews, you're painting a completely different picture to what I understand.
Well,
the system.
It is unique. Yeah. It is unique. Okay. And it's not just that. It's and when I say unique, I'm saying it hasn't been around forever. Like when I was just lucky, man. We had something called the Advocate Operating System, which was based on the Toyota model, which is a car company, which is lean and process improvement. And so I was lucky to, you kind of fuss about stuff and say, you guys have this model, where's the doctors? And then next thing you know, you become the medical director for that, right? So in my role as medical director, I was able to say, they always ask the question, how do we help people heal? And that led to a healthy, I was like, you have to teach them about metabolic health and nutrition and lifestyle. So we started a healthy living program where we got in front of people and taught this stuff, partnered with the Chicago Food Depository, where we would bring food to these programs, teach them how to turn cauliflower into mac and cheese and things like that. And then we started, diabetes programs to prevent it, COPD programs to prevent emphysema and chronic bronchitis, in the food pharmacy. And now we actually grow food. We have a smart farm. All of that's fairly novel in the last, let's just say 6 to 8 years. However, now we're starting to go even further. We knew that social determinants of health were important, but what we're doing now is, what about health equity? If a person in front of me, rather she's in rural America, in a, abusive relationship, or an African American female who's having miscarriages and infant mortality rates higher than her counterparts, let's find out why, and let's do something about it. And if we use that African American female example who's having more pregnancy complications, they found that high cortisol levels was the reason, because of stress, because they deal with stuff that maybe their white sisters don't deal with. And how do we fix it? Well, they need support. So we have, baby showers for our women. We have groups and support groups. And believe it or not, that simple intervention from a health system kind of normalizes the cortisol, because they have support and people who relate. And then you remove that gap of all of those negative effects of pregnancy. So it doesn't have to cost an arm and a leg. the key is to say health equity is a real thing, or health inequities, and how do we make things more equitable? And you'll always see that example where there's like a tree and all the apples are lined up at the same height. And the question is, some people can't reach the apple. So it seems fair because the apples are equally available to everybody. But some people need a stool to get to the apple. And that's that African American female. That's that white woman in rural America who's in this, abusive relationship. So our goal is to reach all of them. And you need health systems to understand that so that they can then provide the resources. Because why bother with healthcare if we have people in front of us, and I'm saying try low carb, and they're like, what's a carb? So if I don't, so if I don't create a path for everybody to understand what I'm saying, and work with the world, and it's hard to remove barriers, then I'm not doing my job. I can't sit here and blame the patient because I told them something to do, and they don't have a way to do it. And my job is to ask the right questions, and then when that doesn't mean everybody needs that. It's just that when people struggle, I know how to peel that onion to say, well, why are they struggling? But what I don't want to do is point at them. If I point at them, then I'm not doing my job. It's just like a leader. I'm a healthcare leader. If I look at if my site of care is not doing well in my region, I need to look in the mirror first and say, what am I not doing well? I do want to make people accountable, but sometimes you start by looking in the mirror, and many times you find, you know what, I could have done a better job. Let me try doing it a little differently and see if my team will then perform. So I think if we were honest with each other and honest with ourselves, I think we'd be more successful. Yeah.
Going back to the low carb stuff, how do you, another kind of form of resistance that you'd probably get is how do you argue the case that low carb is better for people if they have numerous examples or have seen or heard of examples of people getting better on plant-based or doing well on plant-based? How do you navigate that?
That's a great point, because when I was plant-based, I got better, right? And you may have felt better when you were plant-based. But what I find is that if you go to, U.S. News and World Report, and you look at the top diet, and we can use Mediterranean, for example, if you go from a standard American, standard London diet, it's going to be filled with a lot of processed food. I remember visiting London, and it was a little different than France. I took that train, and when I got to London, I was like, it looks like America all of a sudden. It's like I saw all these, fast food places, etc., and I was like, oh my God, it looks completely like America. So I think that any dietary change where both diets, low fat or low carb, will remove sugar, will remove processed food, and what happens is you're going to feel better. The question is, are there things in a plant-based diet that are going to be lacking in an animal-based diet? And for the most part, I mean, a person who's carnivore or keto may need to think about electrolytes, maybe. I did not do electrolytes until more recently when I noticed I was having a cramp every once in a while. But for the most part, you're going to do better. So what I do with patients and I do with my clinical colleagues is I say, what does the evidence show? So there are things out there like the science that's been done by Virta Health. Now, Virta Health, VIRTA, before they started to provide services where they would help people reverse disease like diabetes, they did the research, and they've done, 15 plus trials. And what they found is that the low carb approach was reversing disease and reducing the cost of care, and they proved it. I remember seeing an article from Healthline. It said "Time to End the Fad," and when you read that, it showed the low carb versus low fat studies, and it was obvious that the low carb was more effective. This is a key though, they both can help, right? But it was just more effective to do low carb. And then of course the Public Health Collaborative, they have put together all the studies. So as a scientist, my goal is to rely on observational studies, look at randomized controlled trials. So these groups have either done research or put the research in front of us and has shown that, oh, this stuff is okay. Oh, by the way, the American Heart Association, American Diabetes Association, and the Society of Clinical Endocrinology all put low carb or keto as dietary options. Now, once that happened, and I think for the endocrine folk, it was in the like 2016 or 17. Diabetes was the ADA was like 2019, and then the Heart Association more recently in 2022, I think. But now we have permission for doctors to now say, okay, I'm not outside of standard of care, because these large organizations are saying it. I mean, it may not be standard of care in my health system, but I now have something to lean on. So when people come in front of us and they are curious because they watch a YouTube video, like on my YouTube channel or whatever, right? Now they can say, well, you know what? I'm not as familiar with it, but it appears that these large organizations endorse it. So there is, but am I an outlier? Obviously, I am. If you tried to find a low carb, keto, or carnivore doctor in Chicago, good luck. You can search the Low Carb USA site, Society of Metabolic Health Practitioners, or Diet Doctor sites. They have doctor searches. You're going to find a handful of patients. In fact, my last patient the day before this recording was a person who found me, I think on YouTube, but she was a carnivore, and she traveled an hour to see me because she can't find a doctor like myself. So we are outliers, myself in particular, but my health system is a little bit of an outlier, because if you go into the other health systems in our area, they're not really focused on this like we are. But as a population health organization, we find that there's a benefit of using lifestyle to help people heal, because again, at the end of the day, it's still a business. We're in the business of healthcare, but it's a business. So if we can find ways to reduce the cost of care, then it benefits everybody. So I think that what you've seen is true. This is not standard yet, but I think we're moving in the right direction. Or maybe I'm just an optimist, but because I've seen it in my health system, and I've seen it personally help people. And of course, when I do YouTube and podcasts, I hear stories of testimonies. I know that you can't stop the train, the healing metabolic train. It's just going to happen. There's going to be pushback. And again, it's going to reduce the need for medicines and procedures and surgery. So you're always going to have that world pushing back. But logical people realize that, why would I take a shot every month to lose weight that's going to increase my risk for side effects, and it's going to cost me $1,000 or my insurance $1,000 a month, and I have to take it forever, because when you stop those drugs, you have a 70 to 80% return to the previous weight, and sometimes even a higher weight. But it's not sustainable, and nor can the health insurance. The health system, our country can't afford that. It's cheaper to say eat a steak and some asparagus.
Okay.
That's way cheaper.
Yeah. I like the way you approach it, because again, in a couple of interviews that I've listened to you, you have an MBA, so you look at stuff from an ROI point of view.
Yes.
And interestingly enough, I've just finished reading a book called Doctoring Data by a guy called Dr. Malcolm Kendrick, Scottish doctor.
I like that. I'm gonna look that up.
Yeah, it's a really, really good book, because he looks at basically how effectively data can be massaged to whichever bias that you have. But yeah, the way he looks at, managing his patients and stuff is looking at it from almost that business angle, from that ROI, the return on investment. He talks about how, he can take elderly patients off one or two medications and their health actually improves,
Yeah.
And he said, that's not something that doctors or even the pharmaceutical industry want to promote. The fact that you're taking people off medication and their health just improves. It's a refreshing way of looking at medicine, return on investment.
Dr. Tro, who does virtual medicine, he's the one of the Low Carb MD podcast hosts for those him and Dr. Brian Linskus. But Dr. Tro connected with an industrial company, and if you search for Dr. Tro and research trial industrial company, you find it. And so Dr. Tro when he connected to this industrial company, he said, listen, I could probably help. They were already doing some of the work that we're doing, but what he ended up doing, he said, listen, if you work with me, and it was a low carb methodology, we can reduce the cost of care. So it was a small trial with about 12 people, but with the low carb diet, and the most important part is coaching, right? So they have an app and they coach people and support them. Without coaching, people struggle. They ended up reducing the cost of care per patient per year by $4,000 per patient per year. So how did they do that? Well, people got off of insulin. They reduced their meds. They were feeling better. I mean, so all the things that would increase the cost of care, and it's mainly the medicines, were just disappearing. So we know it works. And if we did what the Doctor in Data guy did, which is why I'm going to get that book, I think it's important that we teach our doctors how to think like business people while understanding, if we do that, then we can have access to data so if we talk about health equity, how do we prove to people that it's beneficial to help that young lady, that white lady in rural America, or that African American person in the urban area who may have miscarriages at a higher rate? Well, we have to show that the program to support them works. So we need data. And once we put that in, doctors and advanced practice clinicians, that's how they think. So, and then guess what? That's how the health system thinks. That's how the insurers think. So everybody involved will then say, oh, this does make sense. But we then also say, if they still struggle, okay, do they need coaching? If they still struggle, do they need to be they may need medicine. Some people need it. Some people need bariatric surgery. It's not that we don't use those options, but it should be the last option. And the bariatric doctor in a health system shouldn't, not be able to practice their craft because they've kept a certain percentage of their patients off the operating table. Just I think about Dr. Ovadia, who wrote the book about cardiovascular disease, and he would in theory lose money by having part of his practice deal with metabolic disease. But maybe we create a system that has a bundle of money, and we're going to pay people even if they don't do that surgery and that's the model we need. We pay people to keep people healthy. And even if they do, they used to do 10 cases, now they're doing 5, but those other 5 healed. That's the model we need. And that'll bless everybody. The insurers are spending less money on surgery. The health systems are keeping people healthy. The patients are healthy. Everybody wins. But that's a big model to shift when we have a fee-for-service model where people are being paid for doing things. So that's why the population health model can work.
Yep.
And I think we have to start thinking outside the box to make that a reality.
Okay, great. So to kind of give you some background on as to why I'm doing these interviews. One, just for straight interviews, beautiful content, engaging with people, kind of in the low carb meat based community, and also 2, to create like a podcast, I don't know if you've listened to This American Life so to create like a This American lifestyle podcast, basically pulling different voices, to create like a more fuller picture of the potential for eating, low carb or meat based. So the first guy that I interviewed, a good friend of mine, he's in Georgia now. I did meet him when he was in New York City. But he's an athlete. He had ulcerative colitis. And he discovered that there's an athlete called George St. Pierre who's in the UFC, or was in the UFC formerly. He had ulcerative colitis as well. So he managed to cure himself through a meat-based diet. I think he's a follower of Paul Saladino. But yeah, could you, from a medical point of view, could you describe what ulcerative colitis is?
I had an irritable bowel issue, right? And so that that's a little bit of a diagnosis of exclusion where you just have stomach problems and they do all the tests and they can't figure out why you have it, right? Well, ulcerative colitis is a little different because if a gastroenterologist takes the time to scope you, they can actually see inflammation in your colon. So ulcerative colitis is an inflammatory bowel disease, and it leads to inflammation and ulcers in your digestive tract. It leads to some people get diarrhea. One of the things that really stands out when I see patients with this, that they may have rectal bleeding. They'll have abdominal pain and, always having that urgency to go to the bathroom, and that sometimes there's not much there. They'll have weight loss fatigue and things like that. And it can affect the colon. It can affect the area closer to where the rectum is, and it's not a lot of fun. So people who have this, their lives are centered around not wanting to be crampy, not, where's the bathroom, and they can't like function in a way that is healthy. So the question is, if inflammation is the most important issue here, how do we reduce inflammation? And one of the things I learned that was very helpful is that, how is it that a diet can help something like that? The thing with low fat is it is a diet that uses a lot of plants, and in some ways, the nuts and seeds and grains are kind of charry. They kind of can cause damage as they travel throughout your system. So although we've lived in a world where they say fiber, 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 I would argue fiber is more irritating. And then it's bloating. So it's going to not only irritate because it's charry, it's also going to make you feel bloated, gassy. And I just think that's what fiber does. Now you transition to like a keto diet. What people don't understand is when you eat meat, that's going to actually, most of that meat's going to disappear. If you put meat in like acid, it just disappears. If you put plants in acid, you're going to be left with that fiber. So meat is actually easier on your digestive system. The other thing I love about that helping a person with colitis, we have to protect our tight junctions in our gastrointestinal tract, and those tight junctions are where we kind of allow things to get absorbed. People who have leaky guts and other types of conditions where the GI system is irritated are likely to have inflammation, likely to absorb things that can harm them. What I love about the keto diet, and this is where there's a little confusion. People say, well, isn't it important to protect your gastrointestinal tract with the microbiome, and the fiber feeds the microbiome and the good bacteria? And the answer is, yeah, it is actually helpful if you look at it that way, because they do create these small chain fatty acids, which will then help to fix those tight junctions and heal. There's a big however. The question is, is that the only way to do it? Can we do it without the charriness of the fiber and all the things that you have to also live with? And the answer is yeah. And one of the small chain fatty acids that are kind of created with a keto or carnivore diet is beta hydroxybutyrate. And that same small chain fatty acid can give you the benefits that you need to heal your GI tract without worrying about the negative effects, the bloating and the charriness of fiber. So I think, again, if a person's in front of me and they have irritable bowel, ulcerative colitis, any of that, and they've had success with a low-fat diet, have at it. But what I find is that most people do better on an animal-based diet when they're dealing with this, because they may shift their microbiome. And that's another thing. People think that your microbiome has to be the standard, microbiome that's like a lot of different organisms, etc. Not necessarily. What if your microbiome is going to be less varied on a carnivore diet or a keto diet? And so, but that's still, if it's doing the job and healing you, it doesn't really matter. But there's one problem, and that problem is, I need to make a video about this. If I change my microbiome where it's not like eating from the, spectrum, and I don't, then the microbiome that I have, although it's good for my ulcerative colitis or my irritable bowel Crohn's, it may be better for that. But then the microbiome may not be good when I decide to eat that plant again. Like, so if I go and eat that plant that needs a certain microbiome to help process that plant, then it may irritate my stomach. So what I find is that people who move towards low carb, keto, or carnivore, you find that many times they don't tolerate some of the foods they could. They really didn't tolerate it previously, but they really don't tolerate it because now their microbiome has shifted to a microbiome that's not really able to process the Brussels sprouts anymore. So they'll say, oh, is something wrong with my diet? No, you just need to stay away from Brussels sprouts. Or you eat the plants that you, like if you eat an avocado and it doesn't bother you, then eat the avocado. But your microbiome will probably be made in such a way that it can process that avocado and that steak. So I think there's the problem with everything I'm saying is that, do we have randomized controlled trials for carnivore? And the answer is we don't. So some of this is anecdotal based on experience. Some of it is based on how we look at science. And you can look at the science of gut bacteria right now and kind of piece this together and understand it. But we do need to have more research to support it. So when we start making recommendations that are vast, but see, some people are so sick they can't wait. And I've seen too many people who have gut issues heal by doing low carb, keto, or carnivore. And the sicker they are with their ulcerative colitis, the more likely they're going to have to go all the way to carnivore. So for me, this is a no-brainer. And I just monitor the things in the blood that, am I worried about saturated fat and all those things that have been debunked? Well, I'll check the labs that make me comfortable that people are doing well. So instead of just doing a cholesterol and an LDL, I'll do a cholesterol particle sizes. I'll do something called the apoprotein beta A ratio. I'll do a fasting insulin. I'll do some of the non-traditional labs. And if I see overall their metabolic health is okay, then that gives us permission, me and the patient, to continue to move down that path. And because I know that the standards of care haven't caught up. I have a whole chapter in my Fix Your Diet, Fix Your Diabetes book that talks about fix your fear of fat, right? That fear of fat is still exists in the mainstream. And although we're starting to see, like the Journal of the College of Cardiology saying saturated fat is not associated with heart disease, and it's actually protective against stroke, but that's not something the average doctor knows. So if you think about my book published in 2017, and we're in 2023, right? Imagine, and we still haven't made it mainstream. So what, are we going to wait another 10 years? And all of those people who never got that information are not healing. We can't wait. So we have to push ahead and have people like me and yourself putting information out there in front of people. Then those people from the ground up get in front of doctors and say, hey, doc, this is what I want to try. Would you walk with me? I know this is not your thing, but would you at least, I need somebody to interpret the study. Walk with me as a coach to support what I'm doing, and then we'll learn together. That's the model we need, because it's going to take a minute before the conventional folk catch up, man.
100%, 100%. So linked to that, is there a reason why someone could follow a carnivore or carnivore-ish diet and develop digestive issues?
I have not seen people follow carnivore diets and have a lot of problems, except when they deviate from the carnivore diet. So is it possible that as you're shifting your microbiome to one that favors carnivore, that could still be problematic? I have not seen that much, but I think it's possible. What I've seen
if you're doing carnivore, let's say you're doing carnivore and fruit, you're doing the Saladino style.
I ask people that want to deviate, find fruit that does not bother you. So it's almost like you do your elimination diet, your carnivore, and then you say, I'm going to add back, give it 3 days before I add anything else. And I think that's okay because I don't know if everybody needs to be strict carnivore. I mean, Dr. Anthony Chaffee is like meat, salt, water. I mean, I don't think everybody has to do that, but I think most of my patients probably shouldn't be Dr. Saladino as well because they may have diabetes. Even if they reverse their diabetes, the banana's still going to raise their sugar. Is it going to raise it as much as it did previously? No, because they've kind of done really well. But they're still kind of vulnerable to that. So what I tell people is listen to your body and do an elimination diet. Start to add back if you're interested in certain things. And if you tolerate those things, then you can stick with it. So I just think that every individual has to do their own little experiment. There is me and you, if we had the exact same diagnosis, whether it's ulcerative colitis, irritable bowel, or whatever, I may respond to things differently. I think there's some, where you grew up, your ethnicity, your ancestors, what were they being fed? Some cultures tolerate grains more than others. So I think that that's why you have to do the experiment because, that's why they have epigenetics. Your environment affects your genes. And I just think that if we blanket say you have to do it this way, that's when we run into trouble. What we do is say, here are some options. Let's try carnivore because you have mental illness, for example. And we know like people like Amber O'Hearn and others who are in this space, they don't even take medicine for bipolar. I mean, you know how hard that is? You know how hard it is to have people in that keto for refractory mental illness with Dr. Georgia Ede and Dr. Eric Westman. You know how hard it is to have 47% of the people in that study go into remission for schizophrenia, bipolar, and depression before they leave the hospital?
Yeah.
I mean, do you really think that's easy? No, there's no medicine that'll do that. So if that's true, then we need to live in a world where they are aware that that exists and we try that and then we measure to make sure no harm's being created. But what we see in practice is that most people who are doing carnivore or keto, they don't have major digestive issues. In fact, most people who are doing these dietary patterns are doing it because they have digestive issues or, they're doing it for diabetes. And doc, I just noticed I'm not having headaches anymore. I noticed that my migraines are gone. I have more energy. Oh, my bowel movements are okay. I'm eating all this meat and I'm having regular bowel movements. I don't go as often, but they're normal. So a lot of times these are things people think are normal to them and then they heal. So I think that but you're always going to have exceptions. There's always going to be a few people, just like a vaccine. Most people get a sore arm. Some people get sick. It is what it is. So, but do we then say that everybody has to change their behavior because a few people get sick? And the answer is let adults be adults. If an adult feels more comfortable with a vaccine, give them a vaccine. If they don't feel comfortable, we want to live in a world where people have a little wiggle room to say, and I don't want to indoctrinate people, although I do vaccines myself. I don't want to indoctrinate people into my beliefs. I don't want to live in New York where babies can't eat meat on Mondays and Fridays. I want to live in a world where you can't eat plants on Mondays and Fridays. That wouldn't be fair either. So I want to live in a world where we allow parents to parent, give kids options. It's okay to teach them what you think is right, but to indoctrinate and to, make that the rule that's not America. That's not London. That's not, Australia. We want to live in a world where people have choice, man. And that's a better model. And we continue to do research. And when we see things are really effective and they're real well done, then we then suggest, hey, this is really well done study and looks like this is a good way to go. You may want to consider this option. Yeah.
So I asked you about ulcerative colitis. The next one I want to ask you about is sickle cell. Have you had any experience of managing sickle cell with a low-carb diet or a meat-based diet?
For some reason, my practice, even though it's an African-American rich population and we know sickle cell disease tends to be more, more present in that community, I have not had a lot of sickle cell patients once I transitioned to a metabolic doctor who deals with this type of approach. Now, so I can't answer that in a way that would say for sure that people with sickle cell, this genetic condition where cells are just sickling. But just anecdotally, if you think about some of the reasons why it flares up, a lot of it is stress and inflammation and things of that nature. So it would be my expectation that people who are dealing with that condition, particularly common in the communities of color, they would also have less flares and they would do better. So I think that's what I can say about that now, and that's mainly because that hasn't been in front of me lately. So I think for most people who have in general, genetic diseases, again, you think about how can my epigenetics help? So how can my environmental things help? And I put, sickle cell in that bucket. When I think about mental illness, I think about keto and carnivore. When I think about autoimmune diseases, I think about keto and carnivore. When I think about neurodegenerative diseases like Parkinson's and dementia, assuming they're not too frail, I think about keto and carnivore. Epilepsy, obviously, keto and carnivore. So I think, I have a video coming out, and it's going to be entitled, something along the lines, is keto the best tool? And I'm going to have a hammer. Is that the best? Is the keto hammer the best tool to fix most things? And the answer is it is. And most of that will be related to too much insulin and why that impacts all the blood vessels in your body. And so I just think that if I have healthy blood vessels, and even those sickle cells that are traveling through it are going to be less likely to impact my body in a way that it would have otherwise. So I think for a person who's checking us out who has that, it would still be an experiment worth trying, because you're going to feel better, get sick less often. And there may be a study out there that already suggests that, but I wouldn't count on it because, I have not seen any sickle cell keto studies, but I'm sure they may be out there,
Another kind of issue would be, so for this guy, Rick, who I mentioned, he's an athlete, and he said one of the things that he noticed in addressing his digestive issues was that with the carnivore diet, or the carnivorish diet that he was following, his joint muscles and tendons were much better, and they felt much stronger than they did in his 40s, than they did in his 20s at his peak. So could you speak to perhaps the benefit of following a carnivore or meat-based diet for joint, tendon, and muscular pain?
When you look at the various factors that equal longevity, many of them speak to muscle mass, right? And you could argue that if not number one, it's number 2 or 3. Muscle mass is critical for longevity. Why? Because if you don't have quads and glutes, you're going to probably be at risk. Because when you stand up, if anybody is checking this out, just stand up. What muscles are you using? So when I see patients, I'm always saying tighten those thigh muscles. So muscle is so important just for longevity. But the question is, how do I get that muscle? And you need essential amino acids to make that happen, for sure. So, and if you try to get essential amino acids from plants, that's going to be a tough sell, because the bioavailability of that is going to be low compared to animal protein. So if you're trying to protect your ligaments, tendons, and joints, they're primarily made of collagen and amino acids. And if the bioavailability of that is much better in animals, then you're going to want to lean towards that. Once you get over the fear of saturated fat and my risk for cancer and all these things that have been debunked, that's the best way to get it. And think about Dr. Anthony Chaffee. Sometimes I'll chat with him and I'll say, so when's the last time you worked out? He said, it's been a month. I said, well, it can't be a month. You look like an Adonis. and I think that some of that is the old muscle memory, but some of it is because he keeps feeding his muscle the right fuel. So if you feed your muscle the essential amino acids it needs, and you're not trying to match the beans with the lentils and all of that stuff, then it's going to be less work. And I only exercise. I use Dr. Ben Bokikio's 15 minutes to health exercise regimen with bands, and I only do it twice a week. It fits for my schedule. It also fits for my patients, many of whom are seniors, and they don't have they're not motivated to go to the gym. They can't afford a trainer, so they do 15 minutes twice a week, slow, intense exercises, and that's enough. They walk, they stretch, and that's all they have to do. We're not. I would love to be on a magazine cover with some abs, but that's not my goal. Is really more about longevity. And even when you look at the blue zones, and we know the blue zones, they actually do eat meat. So I made a video about that. So let's get that out first. But in the blue zones, they move naturally, and that natural movement that helps them to have that centenarian title where many people live to that age. Most of that's what's keeping them. They're using those muscles. Rather, they're gardening for 2 hours or out there with the goats, hanging out with the goats. They're active. And one of the biggest mistakes we make in many countries, mine and yours, is the older folk are at home doing nothing. And if they sit at home and do nothing, they're not going to live to 100. It's just not happening. So I just think we could do better in that space.
Before you mentioned electrolytes having some cramping issues. So one thing that I'm starting experimenting with, which is very kind of goes against the grain of meat based and carnivore, is to include some nuts into my diet. And the reason why I've included them is because I've found out that nuts are high in electrolytes. So they've got, the magnesium, the potassium, the calcium, some of them. So first off, what is your kind of position on nuts? And two, could you give a brief explanation of plant defense chemicals?
If you tolerate nuts, and I would say don't overdo it, you absolutely are going to benefit in terms of electrolytes. When I think about electrolytes in general, I think about what can I do besides supplements. I use Keto Chow. They have a nice mineral supplement with Dr. Kim Berry's face on it. So I have to look at Dr. Kim Berry every day. It drives me crazy. Shout out to Dr. Kim Berry and Nisha Berry, his wife. So, but if you're flexible like my colleague here, because we're not trying to put you in a carnivore coat, right? So if you tolerate nuts, it's okay. Coconut water that's unsweetened is another source of potassium. I do not, suggest bananas. I mean, you can do bananas, but again, it's a lot of carbs with that. I would prefer you do avocados for potassium. That's one of the electrolytes. Dairy, if you tolerate dairy, fermented dairy is always better, kefir, etc. But dairy has a ton of calcium and even sodium, and you also can get a lot of like calcium from your collard greens. That's low in carbs. Your almonds, bok choy, that's low in carbs. So there's great sources, and potassium and sodium can be in your poultry, and even watermelon for those who like that. They get a lot of potassium. So you can get your electrolytes from those types of sources. Now let's transition to this plant. One of the reasons why Dr. Hampton can't tolerate plants is because of all of those defense chemicals. And you hear about these anti-nutrients often, and they're kind of naturally occurring compounds in the plants. And the plants do have vitamins and minerals, but because of these anti-nutrients, your body doesn't always get the full benefit. I mean, I always use the example of spinach and how you only absorb 3% of the iron in spinach, where you absorb 35% of the iron in like a ribeye, and certainly in things like liver. So you may eat all the spinach like Popeye the Sailor Man, but you're not going to get the benefits. But the most common anti-nutrients we think about are things like lectins, which are like, protein-ish, and they bind to the protein found in plants and things like that. And it can really reduce your ability to get the value of the nutrients from that. You think about oxalates. and they can really impact your mineral absorption. And so when we talk about the electrolytes like sodium, potassium, calcium, magnesium, even iron, the oxalates is probably what's in that spinach that led to you not getting all of the benefits of that. You have things called phytates, which are also anti-nutrients, and that's they can affect the mineral of phosphorus. These things are supposed to be great antioxidants, a good source of energy, but if you have those phytates in those nuts and in those beans and things like that, you're gonna not get the full benefit of those beans, nuts, and things like that. So, and there's others, there's phytoestrogens. So what you want to do is understand that you can now, if you're saying to me, Doc, I love these things, you can take the things that have lectins and oxalates, you can soak it, you can ferment it, you can germinate it, you can do those things as well. And doing that will make it less of a negative impact. But my belly does not like these things. So if I eat those things, I will know about it. Now, there are times when you'll say, you know what? I remember when the Black Carnivore was out doing her thing on social media. I really miss her. Please come back. A-Day Fox, please come back. Because I'm trying to hold down this carnivore thing, but she was doing it. she was doing a thing. Yeah, so I hope she comes back. But I'm going to tell you, she would, when she knew, okay, I'm going to have some, I think it was eczema or maybe asthma flare up, both. And she knew that if she cheated, and I hate to use that word, if she enjoyed those things, we're not going to say cheat, she would have a flare. She just accepted that would happen. So I tell people, listen to your body. If you really feel that you would benefit, like I don't eat nuts and seeds often anymore, but man, I used to love peanuts, right? Which is more in the bean fattery, right? If it's on the counter, I'm going to grab a handful and then I'm going to come back later in the day. I'm going to grab a handful, So and what would happen with my stomach just couldn't tolerate. So if I did a handful now and I didn't do more than that, I would be fine. But if I kept doing it, because what you do is you heal, but you still are vulnerable. A person with diabetes and insulin resistance will always be vulnerable. A person with obesity may have flattened those adipocytes, those fat cells, but they can fill back up. A person who has a addiction to the donut at Starbucks or at the Dunkin' Donuts in America, if they drive by the Dunkin' Donuts, those neurons that will remind them of that addiction will fire. So it's best to take a different route. So we have to be honest with ourselves and know that a lot of these addictions and a lot of these things that harm us will continue to harm us. But if you heal and then you have a day, you're out, you're traveling to London. If I'm traveling to visit you, my friend, I may indulge, maybe, because in London you do what the Londons do, right? But I have to know that for Tony, that's not a good idea to do it often. So with that in mind, it gives people permission to not get into the cults. We're not in the ketovore, keto, or even the low-fat cult. We're not in the cult, but we do want to listen to our body, and our bodies will be the best determinant of our health. When I did the Society of Metabolic Health Practitioners presentation, when I talked about, how can carnivores and vegans live in harmony, I think one of the last slides I shared was how I have to get the best advice from myself. So my body is the best teacher of what I should do, not Dr. Hampton, not the randomized controlled trial, not the other influencers. It's what your body says. They will provide guidance. The science will do that, but the best answer comes from yourself. So if you see me talking to myself, I'm just trying to get some advice.
I like that. I like that. Tony, this has been awesome. This has been brilliant. Thank you so much for your time. The usual question that people end podcasts on is, where can people find you online?
Yeah, I will. If they search Dr. Tony Hampton link tree, I think everybody should have a link tree. because it doesn't have to be your video or your content. It can be mine or Dr. Barry's or Dr. Chafee or whoever. And that way you can bless your family in a very subtle way with information. So I would use that. I do have a handout that talks about, it's more low carb friendly. Eat this, don't eat that. I have a video with A-Day Fox, how to get started with
watched it
carnivore.
last night. I watched it
You did.
and I
Man.
commented saying that I miss her as well. Yeah.
Man, I'm glad. I'll comment on your comment. We do, and she just provided so much. So, and then I have a video, how to get started on low carb. So it just gives people foundational information. People who are diabetic, or person suffering from diabetes. I can't stop saying that. The Beat Diabetes YouTube channel with Dennis Pollock. I have a link because he has like 15 foundational videos. So all people with diabetes should check that out. So that's what I would say. And then you'll have a link to the YouTube channel and the podcast. Definitely check out the YouTube channel. I'm going to start making more short videos because people don't always have an hour. And that way they can learn some principles without, having to hear my voice for an hour. So, and I want to say to you, man, I feel blessed. I thank you for what you're doing.
Thank you, sir.
Man, and thank you for adding some color to this space.
Yes.
That's why we like A-Day Fox, and we love all the people who will enjoy this content. But man, there are so many people of color who would benefit, and I just thank God that there are others out there to at least allow that audience to see someone that they can relate to, while also spreading this message to everybody, because everybody on the planet are my brothers and sisters. So I'm gonna keep spreading this message to everyone. And they just had something in India. I don't know if you saw that. They had their first low carb conference in India.
In India. Oh, for real?
Yes, that's huge. If you search that, you'll find it. Because one of my friends, Dr. Salcido, she calls herself the conscious gynecologist. She has a YouTube channel.
Okay.
She spoke there, and they just had it I think it was this past week. Wow. It may be going on this weekend, but yeah, it's awesome, man.
Okay, I'm going to search that.
So check that out. Check that out. Because we're trying to reach everybody.
Yes, please.
And if you don't think, it's not about black guys. Yeah. India has a huge problem with metabolic health. They have more heart disease than any other culture. So we have to reach everybody. So shout out to my Indian brothers and sisters.
Yeah. That's true. I've been looking at some stuff of Dr. Pran Yoganathan. Do you follow him?
Yes, so I'm familiar with that.
He was speaking about his culture, Hinduism.
Yes.
Ooh. Yes. And that's really interesting guy.
Yeah, Hindus worship cows, so we got to give them it's okay that they don't eat cows. They worship cows, so that's okay. And that's the things we have to teach, so people won't look sideways at people for how they eat. Let's work with that, and we'll work around that. Yeah.
Awesome.
All right, man. Appreciate you.
Enjoy the rest of your day, and thank you for waking up so early or doing this early. So.
I have to do it before my wife wakes up because she has honey-do list, so I'm trying to get it in.
All right, man. Enjoy your day.
Take care, man. I appreciate you. You take care, okay?
Thank you.
You too. Bye-bye.